Boa tarde. Hello, everybody. My name is Kurt Barnhart. I'm the new media and video editor for Fertility and Sterility. I have the privilege of being here in Curitiba, Brazil, at the 13th Brazilian Congress for Assisted Reproduction. I'm joined by an esteemed panel, and we are going to review in this Journal Club Global a views and reviews from Fertility and Sterility that was published April 2019. The topic of the entire views and reviews was called Endometrial Receptivity, Evaluation, Induction, and we'll be talking about 5 articles by each of our by our presenters, and I will thank in advance the authors of these articles, which include Richard Paulson, Bruce Lessig, Steve Young, Harvey Kilman, David Frankfurter, Malcolm Monroe, Megan Smith, and again, Richard Paulson. It was a very fantastic views and reviews, and we look forward to talking about it today. What we're going to do is we're going to go down the panel and review each of the articles, hopefully have an organic discussion. I have already 300 registrants online and a full house here of people in Brazil, and I look forward to moving it through. So I'm going to hand it off first to Carlos Almodin, who will talk about the introductory article, Endometrial Receptivity, authored by Richard Paulson.
Okay, thank you, Kurt. My job is to summarize the Paulson papers to start this discussion. Paulson said that endometrial receptivity is a issue that comes based on the observation of not all embryos transferred achieve implantation. Cheng was the first researcher to realize the research in rabbits and realized that we needed to find the time that when the embryo arrived to the endometrial cavity and determine that time to that implantation occurred. Psychoios was the first that used the term of receptivity phase, studying a rodent model, observed the appearance of pinopodus, and he realized that this phase was around 3 days wide. That was validated by Novoty, and it works. Although there are some microkines that reveal that the wide goes until 6 days. Georgiana Jones have a good research in 1949, studying very hard in the luteal phase and the other cycle, and describe 3 categories of defects: follicular phase defects, ovulatory phase defects, and the luteal phase defects. And she described that when the using endometrial biopsy and analyze by the histological aspect and the metaxylin and the eosin, when the embryo was 2 days delay on the was defined about out of phase. And when we started to use oocyte donation, it became very clear that the synchrony between the embryos and the endometrium could be achieved by increasing the amount of estradiol before start the progesterone. The histological analysis showed the endometrium was out of phase. But the histological analysis is very, very failed. And more recently, there are some authors that started to study the molecular signature of the endometrium. This is maybe the best that we can have today. Not is totally trust, but maybe is the best evaluation that we have for today. And today we intended to discuss everything about aspects that could to interfere in the receptivity endometrial.
So that is a very good introduction to what we're talking about here. Do we want to ask any questions about that to begin with, or shall we go on to the next article?
Carlos, I have a question. So you correctly described the paper by Psychos, which was in 1973, for the first time describing the so-called window of implantation. Now, very often we use the terminology window of implantation, and we state that the window of implantation, as published by Psychos, is LH plus 7 to LH plus 11. Do you really think that the window of implantation is so wide? Do you think it is something which initiates abruptly and ends abruptly, or is it something which is going progressively?
This is a very good question. In my mind, I think that the endometrial is a little bit wide, not so a few hours as the people that are describe about the molecular signature, and they think that it maybe is around 4 to 6 hours. I confess that I have very difficult to understand and to believe in this concept. I think that the endometrial suffer a gradual transformation and maybe get the more aspect receptive day 5 or day 6 plus LH. And I believe that the windows is at least 3 days.
So I think that's a good segue into the next article. The next article in this group is called What Exactly is Endometrial Receptivity by Bruce Leslie and Steve Young. Human Fatemi can summarize that article for us with that segue.
First of all, I would like to thank the authors, Bruce Leslie and Steve Young, for writing such a beautiful paper. And I think it's a very challenging paper because the paper describes the so-called endometrial receptivity. Now, the paper initiates with describing the window of implantation being between 4 to 6 days. They refer to a quote of Bob Edwards, who says that actually the endometrium is the last barrier of a successful pregnancy. And also they refer to Georgiana Jones, who described that the luteal phase defect could cause an infertility. But they also describe, actually based on the old papers they have published and others have published, that there are a couple of factors which are important for implantation. We know estradiol is contributing to endometrial proliferation. We know progesterone exposure is required for secondary transformation. And they describe the so-called window of implantation being between 4 to 6 days. Now, they also describe, and this is very interesting, that progesterone itself is downregulating its own receptors, but progesterone is also downregulating the estradiol receptors. It's funny because there have been studies co-administering estradiol to progesterone for the luteal phase support, but we don't need estradiol because the estradiol receptors need to be downregulated during the so-called window of implantation. And they describe factors like alpha V beta 3, it's an integrin, it's a protein, which is actually important for an implantation. And if there is any issue with this factor, which I just described, they know whether the endometrium is receptive or not receptive. Now, women, for example, who have endometriosis, women who have hydrosalpinx, or even idiopathic infertility, if you would start looking to the noise criteria, they would be normal. But there is no presence of alpha V beta 3 integrin. It means they have progesterone resistance. And they describe also that progesterone resistance is not a lack of progesterone. It means there is a resistance of progesterone. And they also describe, based on the previous publications, that actually, for example, someone who has endometriosis, with the co-administration of an aromatase inhibitor like letrozole, you would improve the situation. Someone who has hydrosalpinx, you would remove the tubes, you would improve the situation. They also comment a little bit on the gene expression models, like the ERA test, but also they view that very critically, and correctly so. Because we know that 75% of women who have recurrent implantation failure will come out with a normal endometrial receptivity testing. They also describe a more new test, it's called Receptiva DX, which is looking to another protein called BCL6, and they also describe that the presence of that is also a sign of progesterone resistance. So basically, this is the paper. But I think what I would suggest is to be more critical. To be more critical when we start in the introduction of the paper stating that the window of implantation is 4 to 6 days. Now, why do we say that the window of implantation is 4 to 6 days? And in that paper, they refer to 2 papers. One of them a publication by Navot, 1991, and the other one is a publication by Willox, which is 1999. Now, what did Navot do? Navot took 43 donors, and they put back the embryos in 60 acceptors. Now, they said these acceptors, based on the follicular length and the days of progesterone exposure, they can have between 1 and 6 days of progesterone, and they all can become pregnant. And they put back embryos from 2 cells to 12 cells. Now, you tell me, is an embryo with 2 cells the same like an embryo with 12 cells? No. that embryo, which is 12 cells, will develop faster. And they also describe that basically the shorter the progesterone exposure or the longer the progesterone exposure, the higher is the risk of having a miscarriage. And the same is true through the Willock's paper in GCM. What they did basically, they monitored women with their ovulation and measured from when in blood there is a positive ACG. And they described actually a couple of days, between 7 to 10 days, that these women can get pregnant. But what they don't mention is that those women who had 10 days or 11 days or 12 days of progesterone exposure, they had more than 80% miscarriages. So still the question is the window of implantation really 4 to 6 days? And I'm going to refer to a paper published by Wang recently, and it was an abstract at Fertility and Sterility a couple of months ago, where they describe that the window of implantation opens abruptly. And there is a gradual decrease based on transcriptomics. So I think future studies, we should be much more cautious of defining the window of implantation being 4 to 6 days. Personally, I think it is really significantly shorter. I think it will not exceed more than 48 hours, and I think we should stop referring to papers which are 20, 30 years old, because today we have a much better knowledge on embryos and genetics of embryos and the so-called window of implantation. Noise, it's a good tool we have from the 50s, but I think with the gene expression models we are gaining more and more knowledge.
So the endometrial receptivity window you described is based on science, on transcriptomics. It's not based on a clinical study. How are we actually going to know scientifically when the window opens and closes?
Kurt, that's an excellent question. You need to put back the same age embryo, not a 2-cell and a 12-cell. Because a 2-cell embryo is different than a 12-cell. And this is the Willock's paper. This is a New England paper from 1999. The Navot paper from 1991. So they put back 2 cells and 12 cells embryos. But a 12-cell embryo is an advanced embryo. A 2-cell embryo is a slow embryo. So what I would like to see is a study where a blastocyst, which has preferably, that can be debated, chromosomally tested, on a certain stage, and that is being put back after different days of progesterone exposure. This is what needs to be done, not only to look at the gene expression model, but also on clinical level. How many days is the so-called window of implantation? And I think that is missing.
And obviously the problem with that is experimenting with human embryos makes that a very difficult experiment. So in the meantime, we have to go with the very high quality science to make our clinical recommendations. And that's why I want to transition to the next paper, which was entitled Clinical Approach to Recurrent Implantation Failure, Evidence-Based Evaluation of the Endometrium by Harvey Kleinman and David Frankfurter. Dr. Nakagawa, please introduce us to the paper and continue our discussion.
Thank you for the invitation for this journal club. I would also like to thank the authors for this enlightening paper. I work in Brasilia in a clinic, private clinic called Genesis, and I'm the president of the Brazilian Society of Assisted Reproduction. Besides endometriosis and recurrent miscarriage, probably recurrent implantation failure constitutes one of the most challenging topics in our daily practice. It's estimated that about 1/3 of the implantation failures is related to the embryo causes, and the remaining causes are related to altered receptivity or problems with the embryo-endometrial interaction. We have developed a lot in embryo quality evaluation, but endometrium is a complex tissue, and probably to analyze its function is not so easy. Endometrium should be receptive for good quality embryos to attach, let the trophoblast invade, but in a limited way to avoid aggressive incursion and placental abnormalities. And if pregnancy does not happen in that cycle, prepare for the next one. So many potential markers have been evaluated, but no one probably is ready for function analysis. There are some commercial available tests for endometrial assessment based on dating, function, and inflammatory markers we use in some countries. We don't have here all of them here in Brazil, but I think we still have to wait for worldwide availability and wait for more studies to have conclusions about these tests.
Do you have specific tests that you routinely perform in your practice?
We have some, for example, based on endometrial dating, and to like ERA, endometrial receptivity test here. We have one to analyze infection, chronic endometritis, and to analyze the endometrial microbiome here in Brazil.
Do you consider all of those tests on all women or only in particular areas?
Okay. First of all, I think we have to eliminate the other possibilities, like anatomic defects, and then reserve these tests only for specific patients. When you don't have any other way to explain her recurrent implantation failure, this is a tool for you to use. But I think it's interesting to explain to patients, because nowadays patients go to Google and then ask you many questions about the recent research, and you have to be prepared to indicate the best way for that specific patient.
Thank you. I think that's a very practical approach. To stay in line with the views and reviews, we're now going to move very briefly to talk about some anatomic reasons, which you said need to be excluded first. So there actually was an article on uterine polyps, adenomyosis, leiomyomas, and also endometrial receptivity, authored by Malcolm Monroe. Jose Franco Jr. is going to have the privilege of summarizing that article for us.
Oh, I'm Franco from Brazil. That's okay. I would like to say that is a very nice revision by Dr. Monroe about these three clinical important points. About polyps, I think that he described some important points for discussion. About spontaneous resolution, 27%. And when you speak about the resect or not resect the polyps, I think it's a good discussion, because there are only one randomized paper, but IUI, 215 patients, and good results, good outcomes for if you resect the polyps. However, there are other papers showing that if you have an IVF, ICSI, polyps, 1.5 centimeter, below 1.5 centimeter, no difference, you resect or not resect polyps. This is a good question for discussion. About the number 2, adenomyosis, for a long time in my life, I had a lot of difficulty to understand about adenomyosis, because only you take out your uterus to pathology, check. But now we have, last 10 years, 5 years, magnetic resonance imaging that give for you better information. The best information will be the interface between endometrial and myometrial. This is a good point, because in this discussion, Morgan said that the increased peristalsis will be the most important point to make some disturb and the sperm transport, and maybe the embryo transport. So this is a point for good discussion about adenomyosis, I think so. About medical therapy, I think it's too difficult because it's too aggressive, but in the future. And all these three types, I go to speak about myomas, and all this time, the Muro give you many information about the research, about the many ground factors, integrins, everything you know, but no clinical application until now to identify what polyp really you need to take out, or what type of adenomyosis really give for you biochemical information or other information, gene expression, to make individualize the patient treatment. For the last point about myomas, I think it was a very nice revision also, but said every time that the people needed to take some classification, like FIGO, to publish your paper. In literature, you have many published, but no specific classification. FIGO have a very nice classification, but we have a few papers who follow this idea. And the other good point is submucosus. Really, everybody, not everybody, but a great part of the clinicals agree that you need to take out submucosus. But, however, the intramural is more difficult because if you have a little myometrium between the myoma and the endometrium, is maybe having some work different if you have only myoma just close to endometrial. That's a difference. This more discuss in detail this point, important point to intramural. But about the other location of myoma, subserosal, no important. But he come back to discussion the size of myoma. You need to take out myoma below 4 centimeters, about below 2 centimeters. Numbers is difficult. I think is for clinician is too difficult because and every time you find patient could get pregnant, we have a lot of myomas included submucosal myoma. I think at this point is 3 points are many discussion. I think it would be good for everybody go into this point.
So I think I could summarize what you said in the article, or how you reviewed the article, see if you agree. Polyps are relatively minor to take out, and the consequences of taking them out is small. Most people take out polyps. Myomas, it depends on where it is, and you have to balance the risks of the surgery to the risks of the myoma. But adenomyosis intrigues me. I'll ask the panel, how would you treat adenomyosis prior to re-engaging somebody with fertility?
Yeah, I think I have a possibility clinical treatment with the block the hypothesis analogs, agonist for 2-3 months before you use go to IVF or other things like that. But for surgical treatment, maybe don't have space. Yeah. But clinical treatment with analogs, I think it will be a good idea for us before something.
I absolutely agree with you, but I think there is one point we need to emphasize, because, I mean, we are speaking for a journal which is representing evidence-based medicine. Do you know what is the evidence of randomized controlled trials to answer all the questions just discussed? Fibroid, polyps, septum. How often do you do a hysteroscopy with a woman who comes for a second child and who delivered at 40 weeks without any problems, and she has a full septum? And we tell her we have to remove the septum. But she tells you, but I delivered. But then you go to PubMed and you find so many publications of miscarriage, but all of them retrospective. The same is the truth for fibroid. We do not have a single RCT looking on the impact of various fibroids. And what you correctly describe based on the size and position, of course, if she's symptomatic, is a different story. Polyps, like you correctly said, there is one study, but this is only IUI. And also, we published a paper many years ago with Yeneke Cassius, 1,000 patients. We did a hysteroscopy. And basically, what about the inter-observer variation? What I see is different than what you see, the way we are evaluating it. Now, going back to meiosis, I think this is more or less in the same entity like endometriosis. We know that these diseases, they have an impact on the production of alpha V beta 3 integrin. And studies from Leslie and Young also have shown that if you would suppress with aromatase inhibitors or GnRH agonists, you might be able to normalize that. So this is the way, but this is theoretically. How it goes in practice, we need an RCT to answer this question.
Yes.
Yes, very, very well said.
Besides, there are some research with radiofrequency surgery to this case recently. I believe that agonist is the better treatment for this case.
Yes. I do agree that we have had many studies on polyps and fibroids, and I'm still not clear what the right answer is. So maybe we can talk about that a little bit longer. So that's another good segue into how much do we have to do and what we think to get a normal situation. And I think that's very emphasized in when we're talking about third party, where you're taking a healthy woman to being able to receive an implanted embryo, and what's the workup for somebody that theoretically is normal. So we're going to hand that paper over to Matthias, who's going to talk to us about endometrial preparation for third-party parenting and cryopreservation of embryos. Thank you.
Thank you, Kurt. My name is Matheus Rock from Brazil. I work in São Paulo in Mater Prime. And first of all, I'd like to thank you, Kurt, for the opportunity to be here in the Brazilian meeting. It's a great pleasure for us to have you here. And I'd like to do a live invitation for the next Brazilian meeting that will be in 2020, that you can come to our meeting. Now I'd like to congratulate Smith and Paulson for their study. I think that we have already developed the embryo. We did the most important things concerning the embryo, and now we are at the point to put the cherry in the cake. We need to do the embryo transfer and need to try to simulate what occurs in a natural pregnancy and a natural cycle. And not only the third party, but also we are doing many frozen towel embryo transfers. And then this review is really important to show exactly how to put back the embryo into the uterus, following exactly steps for endometrial preparation and also the luteal phase support, what would be the best. It's important to have in mind that to achieve a live birth, we don't need only a good embryo, but we also need the perfect interaction between the embryo and the endometrium. Then, if you go to follow the menstrual cycle, we need to think about the endometrial preparation starting with estrogens, estradiol. And in general, we have different routes of estradiol administration. We can use it orally, we can use transdermal, and also vaginal estradiol. Importantly, if you compare many Cochrane reviews and also some studies that were published in Human Reproduction Update, we can see that there is no difference in the outcome when compared these different routes of administration. If we use an agonist, GnRH agonist to block the hypophysis, or if you just transfer the embryo after a hormonal replacement therapy or in a natural cycle independently, in general, the outcome is the same. I'm not talking about obstetric outcomes, that this is an important issue that we discuss later, that it was not covered in this review. But thinking about the estrogen, estradiol, we can use it orally because it's easy to administrate, it's cheap, and in general, it's effective. The timing that we need to use, we don't need to worry about the length because there are many studies showing that we can use for 3 weeks up to 4 weeks, that the effects on the endometrium will be exactly the same. We are not affecting or jeopardizing the endometrium if used for a long period of time. And there is also some studies showing that we can get pregnant and adequate endometrium using 5 to 7 days of estradiol. And then this is important. But in general, after 10 to 14 days of estradiol administration, we can evaluate how is the endometrium and also continue doing the planning for for the embryo transfer. The other routes, the vaginal in general, we can use vaginal route. Sometimes if you use vaginal, we can see the estradiol levels, the circulating estradiol levels are much higher than we have when you use oral drugs. And also the transdermal, sometimes we have better preparation because when you think about the correlation of estradiol and estrone, this conversion when you use transdermal is lower than when we use orally. But if you use orally, transdermal or vaginal, you can obtain exactly the same outcomes. If you think about the thickness of the endometrium, in general we look at least 7 millimeters, but there are also many studies showing, some studies showing that we can get pregnancy even with a thinner endometrium. Some studies showing 3.5, 4 millimeters that you can get pregnancy. But it's always a challenge when you have a thin endometrium that you can prepare with only estradiol. What we will do for that, we can also discuss this later, what's the best evidence for that. We have already performed the estradiol or the endometrial priming. Now we need to look at and think about the luteal phase, how to do the luteal phase, how to translate what you have in a natural menstrual cycle. Importantly, like Human told previously, in theory, it would not be necessary to use estradiol during the luteal phase. In theory, only with progesterone, we would have an adequate endometrium, a receptive endometrium to perform the embryo transfer. Some studies can show that with low levels of estradiol, something like 20 picograms per milliliters, we can have an adequate endometrium. It will not affect the endometrial receptivity. Probably, the most important thing concerning the luteal phase support is the timing between the day that you started the progesterone and the time that you are going to do the embryo transfer. And this is another important issue because I'm sure that all about us, we take care about this when we started and we performed the embryo transfer. If the window of implantation was so wide, like we say 5 days, 7 days, why would we be taking care about this? Then I agree with Human that told that in theory, I believe that the window of implantation is shortened than when compared to the past studies. Importantly, when compared the route of administration, vaginal or intramuscular, if you are planning a fresh embryo transfer, there are no difference on them, and there are some studies comparing these in frozen towed and third party. The most recent study that was published last year in Fertility and Sterility by Divine, it was a randomized study, and they concluded and they suggested that intramuscular progesterone, we can achieve higher live birth when compared to vaginal only use. However, in this study, they did a big mistake in the methodology. Like, the window of implantation is really important if you are planning to do a blast cyst transfer. Independently if it's a day 5, day 6, or day 7 blast cyst, in general, we need to think that we need to use 5 days, 5 complete days of progesterone, and we transfer on the 6 days of progesterone use. In this study, they didn't explain why, but in the group that they use intramuscular progesterone, they did exactly like this. They used 5 days complete of progesterone and did the transfer following the embryo and did a single embryo transfer, single blast cyst transfer on day 6 of progesterone use. Although in the vaginal group, they did the transfer 1 day previously. They just used 4 days of progesterone, and on the 5th day, they did the transfer. Then this is one aspect that I would like to comment concerning this review, because they comment about this study, but they didn't do any comment about this problem, a big mistake that they did, that Vining and other authors did in the methodology. And this is really important to have in mind. And the timing. I think this is important and probably the most important aspect in this study. If you are doing a cleavage stage embryo transfer, in theory, to have 3 complete days of progesterone, if you are planning to do a blast system embryo transfer, in general, think about 5 complete days of progesterone, then thawing and performing the embryo transfer.
That would argue that the window of implantation is more narrow than we talked about.
Yeah, I
Thank you
believe
for
on
the
that.
summary. So I want to go back. I have been polling our audience while people were speaking, and I want to compare some of the answers to the group we have here in Brazil. First of all, I want to share that more than 25% of our audience is from South America. We also have people attending from Europe, from North America, and from India. There are 2 people presenting from other, so we'll have to track down where in the world they are. So I was able to ask questions electronically, and I have the answers. So I'm going to ask the questions with the show of hands here, and then we can compare. I want to go back very basic, and then we'll talk more about some of the molecular aspects of it. But first, the question which is on the screen here is, what tests and procedures do you routinely perform to assess the endometrium of a woman just starting infertility treatment? So this is not anyone with implantation failure. What is your routine aspect? So how many people perform an ultrasound? Okay, it's not everybody. How many people would form an HSG? Again, a minority, I'm guessing about 5%. How about a hysteroscopy? Few, but some, okay. Does anyone do endometrial biopsy routinely for dating? No hands, okay. Endometrial biopsy for infection? There are a few. Okay, this is not too far off from what we got from our international audience. We found that 43% of people routinely do an ultrasound, about 25% routinely will perform an HSG, a smaller number, around 15%, would perform a hysteroscopy, and actually just a few people are performing, 12% are performing endometrial biopsy for infection or for dating. What about ERA? How many people do ERA routinely? In the audience, we have 6% of people doing it. All right, I'm going to ask a slightly different question. What about if I change the question to somebody with implantation failure? These are the exact same choices. I want to see if at our clinic and our experts, what they do routinely for someone now with diagnosed implantation failure. How many people would perform an ultrasound? My entire panel will be, and probably half the audience. What about an HSG? You can have more than one. It doesn't have to be one test. So would everyone perform an HSG? Yes?
May I justify? Not only for endometrial evaluation, but at the beginning of the fertility investigation, we do, and we may have some problems in the endometrium, like adenomyosis, we can see, uterine problems,
Okay.
and or any image failure for myoma or polyps.
Very good. Just to compare the audience, let's finish one more time. How many, if in implantation failure, how many people will now do an endometrial biopsy for dating? Very few. How about endometrial biopsy for infection? More. So we're going to do more for infection than we are going to do for dating. And how about ERA in someone with implantation failure? That looks to be about 25%. Does everyone do ERA here on the panel for implantation failure? Not everybody. So according to our audience, 40% would do an ultrasound, 25% hysteroscopy, 25% HSG, 12% hysteroscopy, biopsy for dating 12%, and ERA about 6%. But I have a trick question here, and I want to ask this before we get comments. I just said implantation failure. I want to go down my list. How do you define implantation failure? Start with Mateus.
May I start? Kurt, I have a great, I've been working with reproduction since 2010. Daniel, 2010. 2009, yeah, my professor. And nowadays I compare infertility to oncology. In oncology, we perform many treatments that studies did only showed that, okay, with this drug, very expensive, you can have 10, 15 days additional in your lifespan. This is for your comfort, this is for thinking about quality of life. We always talk in the studies about cost effectiveness, we talk about implantation failure. We never talk about the psychological burden of one miscarriage. We never talk about the psychological burden of one menstrual bleeding or a negative pregnancy test. I think that we are on the period that we are working in a patient-centered medicine, that we need to focus on what's the best for the couple. We need to use the scientific evidence that we have, but we need to talk to the patients what would be the opportunities, what would be the strategies if they fail, and if they want, I think that they have the possibility to do some tests before they fail. The dropout rate of one IVF treatment, one failed IVF treatment, is around 20 to 30% after one complete IVF treatment, and this data, it comes from the countries where the government pay for the treatment for at least 3 or 6 IVF treatments, and 20 to 30% of patients that fail in one IVF treatment will not go to a further treatment.
So Mateus is giving one end of the argument,
Yeah.
which is that perhaps we should test everybody before they even have a chance to fail.
I'd like to talk to patient,
But I will present the other side, and I'll ask everybody, which is, in the best hands, IVF is working 30, 40% of the time, which means a lot of people are failing for no pathologic reason. So we have to make a distinction as physicians on when we give extra tests, when we call somebody implantation failure, and when this is just a bad luck for an IVF cycle. So I want to hear, let's go down the list and hear what we consider implantation failure, because one, it should be a definition for us to do research, but two, it clearly is our description to the patient that something is wrong and therefore you need more testing. So what do you think?
I think that implantation failure for international societies is if you have to treat embryo transfer, euploid embryos, and without successful, this means implantation failure. But it depends on where you work and your country you live. For example, for us in Brazil, that the treatment is very expensive, and the patient pay for everyone. We have no insurance, we have no any kind of help. In my clinic, we consider just one attempt. If you have implantation failure, which is a very good embryo, we consider this patient that deserve appropriate evaluation and different evaluation. And we have to afford everything that we can to try to help her.
Okay.
So first of all, I think, like you correctly said, Kurt, the first question is, how do you define a recurrent implantation failure? Now, you might say 3 consecutive failures of implantation of euploid embryos. It means you have one variable of a successful pregnancy, which is an embryo, but then you come to the endometrium. The next question would be 3 subsequent failures of a possibly euploid embryo in a stimulated cycle or in a frozen cycle. Because a stimulated cycle, we know, is less receptive than a frozen cycle. Then if you go to a frozen cycle, was it an HRT cycle or was it a natural cycle? If it was a natural cycle, was it a managed natural cycle where ACG was administered to plan, which we know due to publication in FNS many years ago, which we did, that the receptivity of endometrium goes down. Now, if you transfer an euploid embryo in a correct window of implantation, but the correct window of implantation, which is a matter of hours, not days, then we speak about the recurrent implantation failure. Now, you ask, would you recommend to do an ERA testing? We know that in 75% of women with recurrent implantation failure, ERA is normal. number one. Number two, we just published a case series of patients with abnormal ERA, which we neglected, and they got pregnant. Because you cannot reflect an ERA which is done in an HRT cycle with an actual cycle. So I think we need to be more critical also of the definition, like Kurt correctly said, of what is a rectal implantation failure. Of course, it's a joint venture between endometrium and embryo, but we need to have a look at both of them.
So this is very, very nice issue, okay, because I confess that I feel more confident in TOS cycle using the prepaid cycle. Because in my mind, maybe this is false feeling, but I think that I have a blocked ovary, I blocked the hypophysis, and I have the uterus completely empty. I have the probability to create a new endometrium, okay? So maybe it's false, I confess. So I know that Fatemi loves the natural cycle, am I right? Yes. And I feel, maybe it is false, but helping me to understand better, that how it's possible to get a good control about a natural cycle that you have no control about anything. For example, if the patient is in ovulatory cycle, you have to follow the follicle development until 20 millimeter probably, and use HCG, and how you start the progesterone. And in patient, for example, PCO patient that has no ovulatory cycle, how you can do or manage this type.
So I want to keep it general for a second because I want to give time for people to ask questions themselves. So Dr. Nakakawa, how do you define implantation failure for your patients?
I think they have already defined it very well, and a unique comment I would leave here is that people make confusion, especially patients, even they have bad embryos sometimes, they are having the whole evaluation for recurrent implantation failure. I think this is a point we have to discuss more.
Dr. Franco.
I think that a big problem here, I don't need to define implantation failure. For the medical point of view, it's correct to define implantation failure. For the patients, I think it's better for us to prevention implantation failure. That means your routine to IVF, in my opinion, will be very high. Many examinations, because it's difficult to talk with patient after one failure. Oh, I forgot to ask you about to take blood to see if you have some genetic problems, like translocation and other things. Oh, doctor, please, but your routine, why you don't do that? Now, I lose my opportunity, I spend money. So I think implantation failure is only one definition for research of something, or 2 or 3 or 4 or 5 failure when you transfer embryo. But for the patients, one implantation failure is terrible. So my routine is too strong. So the patient say, why I need to pay for that? Because I don't have other things to talk with you after failure. If some embryo problem or some endometrial or something which occur during the process of the IVF. But for me, it's too difficult to say for her, okay, I forgot one very nice examination, error. Why not? I don't believe in error together because we don't have a randomized paper about that. Sorry, but we talk every time about the medical evidences, and you talk many times about error. Show me one paper randomized. Not to do that. Only for stimulation cycle, not for natural cycle, other things. Please.
I'm not advocating error.
No, it's a discussion. Okay.
I'm
but a
just trying
discussion
to have
here
right.
is for discussion, no?
Right.
Perfect.
Yeah.
I go to do that. Why not? If you show me, it's not one personal problem for any new technology.
Yeah.
The problem is you have some medical support, one randomized.
Yeah.
It's okay. I accept. I'm
Matthias
not a radical man, okay?
Poor Dr. Roque is back there wanting to speak up. So I used you as an example, saying that you were advocating that any failure for IVF is implantation failure, but let's see if you actually believe that.
I think that these definitions, they are really important for scientific reason to perform studies. We need like Bologna criteria for poor responders. We need to have a definition about what would be a poor responders in studies to compare similar population. It's like implantation failure. Then I used to say to the patient, okay, you don't have the definition of implantation failure, you didn't fail it. 3 embryo transfer, 3 euploid blastocyst transfers, but you failed. We have these opportunities to do for implantation failure. Would like to do these tests, but I agree, the definition, I agree that is around 3 failed euploid blastocysts, but for me, we can't fail. I think that some of implantation failure are doctor's failure. This is my opinion.
Yeah, I'm trying to purposely set up a dynamic here that in medicine, there is a true definition. When you reach this criteria, you use this therapy. But we are, I think, adopting a new lexicon that anyone that fails IVF, the problem must be implantation failure, and now we're adopting many tests without support that maybe worked because we think they may work. So I'm trying to decide, for me, does somebody have to reach a definition before I use these tests, or can I use them on anybody? So I'll ask all of you, what do you think about that dichotomy? Do we need to have a specific definition, or are any of these tests available to whoever wants them?
I think it's important to have this definition, mainly when you are considering, like you are telling implantation failure after 3 euploid embryo transfer. But are we doing PGT for all the patients? We are not doing that. And then, okay, you can define implantation failure based on embryo quality. But what is this classification? Then I think that we are misleading the ideal classification of implantation failure, and we need to listen to the patients, but we need to have this definition. I think that we are not on that point.
Okay. As we come back this way with your opinions, please, this is a perfect time for us to get up and ask some questions as well. But let's have Dr. Franco comment first while we get up and someone wants to come to the microphone.
I agree with Mateus.
Okay.
Because there are many, if you go to RBM online, you find a good paper. I forgot the name of the author, please, I'm sorry. But he defined a minimal 20 different definitions of implantation failure in the paper published during the last 20 years. So if you agree, no, we need one meeting like Bologna criteria, but today, many people don't agree it's Bologna criteria. If you make a meeting to implantation failure definition, I think it will be a very nice meeting, but real definition doesn't work.
So I put up this, I asked this to the group online, I'll ask it to you as the last question to the audience. Who performs endometrial scratching? Occasionally. So I'm using this as an example because there are randomized trials that perhaps this doesn't help. We could still argue about the literature, but this was designed for people with implantation failure. So many of these other therapies we're talking about are also designed for implantation therapy and failure, and we just don't know if they work yet. So let's open up to everybody else. You were about the same as the audience, by the way. The audience, around 50% did it 5% of the time of their cycle, not often. So it's still a tool, but not commonly used. Are there any questions from the audience? Please.
I would like to go back to the window of implantation. If we transfer an embryo day 2 or day 3 or day 5, and you can have a good result, a positive test and a pregnancy. Isn't there a difference? Okay, you have a difference in the stimulated cycle, in the natural cycle, and prepared with estrogen and progesterone and so on. But as Mateus said, we have even a pregnancy if you have an endometrium as 4 millimeter. So isn't there possible that the embryo itself can change this window of implantation? If something in the embryo contact with the endometrium, isn't it possible that this may be the difference?
It's a good question. So the question is basically, how much is the embryo involved in endometrial receptivity? Please.
Thank you for the question, but I could counter-argument your question. How do you explain that an embryo is implanting in the tube, on the ovary, or on the liver? The embryo can implant anywhere. Do you know that the endometrium is the worst place for an embryo to implant? It's the worst place, because the embryo can implant anywhere. But do you also know that the endometrium and the embryo, they communicate with each other? There is beautiful work from Nick Macklon's group where they described based on the communication of the endometrium and embryo. On the other side, when you say thickness of endometrium, because that is a very controversial topic, we know, and I don't know if that paper has been published yet, that studies of ERA, looking in 238 genes of the endometrium, have demonstrated the thinner the endometrium, the lower is receptivity. But if you have an ongoing pregnancy with a very thin endometrium, we have had pregnancies with 2 millimeters. What will happen? The problem is not getting pregnant. The problem is the vascularization and the placenta formation and premature delivery of that baby. So it's not only having a positive pregnancy test, it's also having a correct live birth with a correct birth. And I think we also have to distinguish when you say endometrium is thin. Let's say you have an endometrium of 4 millimeters. Do you think 4 millimeters in a natural cycle is the same like 4 millimeters in an HRT cycle, is the same like 4 millimeters in a stimulated cycle? I don't think so. I think there is a difference. They are all 4 millimeters, but there is a complete difference between these groups. I don't know what others think.
I completely agree with you, but it's possible allow to Fatemi to answer my question?
Sure.
About? Okay.
So the question you were asking is, for example, if you have a patient and you go with a certain size of follicle, you administer ACG to make the planning in a semi-natural cycle. Now, we studied that, and we published that in Fertility Sterility 10 years ago. We had to stop the study because the pregnancy rates were half in an ACG-triggered cycle as compared to a natural cycle. Now, why is that? So what do we do now in a patient who is naturally ovulating? Now, first of all, I'm a gynecologist. My excuses when I'm going to say women are weird species. So if you have a woman coming to your clinic telling you, I have a cycle of 28 days. Doctor, I swear I'm going to put my watch and at 28 days I have my cycle. When she comes for a cryo cycle, you can be sure that she will not ovulate day 14. That's what's going to happen. So 25% of women, because they know they have to ovulate, they will not ovulate. The ovulation will be later. But if you tell them in advance, that's fine. So we tell them, look, even if you are regular, it might be postponed. So what do we do? First of all, there are 7 billion human beings on Earth, and they were mostly conceived naturally. It means the nature knows more or less what's the best way to go ahead. So we see women on day 2 or 3 of the cycle. We just do a scan to make sure there is no cyst, that everything is correct, that she's bleeding. If the cycle is, let's say, 28 days, we see the patient back between day 10 to 12. We do a scan to make sure that the woman is developing a dominant follicle. Because if she belongs to the 25% who will not ovulate day 14, she will not have a dominant follicle, so you don't need to see her back. Let's say she comes back on day 12 and she has a dominant follicle. You want to know what is the granulosa cell activity of that woman, how much steroids, how much estradiol is she producing. So we do an endocrine profiling when she has a follicle of, let's say, 12 to 14 millimeters, just to have an idea how much estradiol is she producing. You have a certain value. You know that this woman is going to ovulate in the next 2 to 3 days. And you have the values of estradiol, how much it's producing. You see back the patient after 2 to 3 days. Now, when we ask gynecologists, and this is basic knowledge, what is an ovulation? Everyone will tell us LH goes up, progesterone goes up. Yes, but it's more complex than that. The first thing which happens, LH starts to rise. There is an interaction between the hormones. LH and FSH start to rise. This is the first moment of ovulation. When LH starts to rise, and you have captured that moment on the same day that she's ovulating, but estradiol is increasing as compared to the previous test you have done, it means she started to ovulate. The day after, 1 day after initiation of LH rise, LH is still up, estradiol starts to drop, but progesterone is still down. This is the first day after initiation of your LH rise. The second day, LH is still up, starts to go down, but still elevated. Estradiol crashes down, and progesterone starts to go up. Do you need to measure every day? Of course not. Because within these 3 days, if you have one, you know exactly where you are. You have your reference value based on a dominant follicle, and the rest, one blood test, day 14, day 15, and you can plan accordingly. Without the ACG, because if you administer ACG, you have a very rapid increase of progesterone. The first ACG that the human body is exposed to is when the patient is pregnant.
So unfortunately, we're a little bit out of time. We can continue this conversation offline after the webinar closes. But I do want to go through and give everybody a chance to summarize their thoughts on what I think is a really exciting point of view. How do we deal with receptivity failure? So in a minute or so, please go down the list. We'll start with Matthias and summarize what you think the key points are and what you want our audience to remember.
In my opinion, the key points is that we need to synchronize the embryo to the endometrium to achieve the best outcome for that patient. We need to listen to the scientific evidence, but we also need to listen to our patients. And just one additional comment that in the review they didn't cover this topic, but in general, when we talk about frozen polymer transfer, most of us, we think about hormonal replacement therapy. But there are recent studies published in January in hypertension, another study published in AJOG, and now in human reproduction, showing that the cycles that we don't have the corpus luteum, we don't have relaxin. And without relaxin, we increase the risk of placental problems, and we also increase the risk of preeclampsia and hypertension during the pregnancy. And this is an important aspect to be discussed because it's easier to do our hormonal replacement therapy. It's easier to do and to the patients to program everything. However, probably we are increasing the risk of these patients when compared to natural cycle that we have a corpus luteum. Just these additional comments.
Thank you. Dr. Franco.
I think that we needed to talk about the not a window of implantation, but door of implantation, because a window is too small. I think the implantation is like a door. It's more than you think that's possible to do that, because you put the embryo, slow division, and stays without, it takes pregnancy, is out 2-3 days from the perfect endometrial. So I think we have a door. In this door, there are many influence of the hormones, influence of the embryo, influence of the many factors, genetical factors, ground factors. I think it's too difficult. I think for me, it's difficult to understand what is really receptivity, endometrial receptivity. It's difficult for me. I don't know. I'm a clinician. To precise exactly all these points we discussed today.
It would be good if we had the key to the door.
Yeah, I think so.
Please.
Endometrial is a complex tissue, and probably only a set of sophisticated methods will assess the whole functional potential of the endometrium. A flow chart to propose is first to investigate and correct pathological conditions that we know may influence embryo implantation. And for the other test, we told about functional evaluation of the endometrium. We have to talk with our patients about the limitations, like all of them need endometrial biopsy. That's costly, that's time consuming, and it hurts. And show the strengths and the limitations of these methods. And if our patient wants, share the decision.
Very good, thank you.
I think we have to learn to be more critical on a definition of window of implantation. I don't think that the window of implantation is 4 to 6 days. I think it's rather 36 hours to 48 hours. I think prior going towards comparing a frozen cycle with a fresh cycle, we need to define what is the best cycle regimen with the best window of implantation in a cryocycle. Because we cannot publish papers in New England or in the Lancet comparing two things when we don't know what is the best window of implantation in a cryocycle. And I think, as Mateos completely correctly said, we also have to think on the obstetrical complications. And as he correctly mentioned, there has been recent studies describing clearly that preeclampsia and hypertension is significantly higher in women who have no corpus luteum. So we need to be more critical, and we should stop following dogmas as we have done in the past. And I think this window of implantation is something where we need to be more critical on.
So I believe that you are on the verge to understand about the communication and embryo and endometrium. We need more research, we need more information. Unfortunately, we don't have yet the good solution for everyone.
Thank you all very much. I want to just very quickly comment to some of the people that were chatting with me online. There were questions about immunological aspects of implantation failure, and I think that is a venue that we will learn more about. I can't summarize that in 30 seconds, but a very, very good question. There was also a question about blood flow and implementation. There are people that use agents to increase blood flow, I think with relatively scant information that it actually works, but I can't diminish that blood flow has to do with implantation failure. And finally, the one thing we didn't talk about was male factor, and does that contribute? And someone suggested that perhaps DNA fragmentation might be an issue of implantation failure. These are all wonderful questions. As an evidence-based guy myself, I hope that we will look at these critically, because these tests have come on the market very, very quickly. There are now tests that test the microbiome. There are now tests that test infection, the window of receptivity, and there's very good rationale, but not very good science behind them to show that they work. So I will get the final say in this. So to those online with me, good morning, good night, or good evening, wherever you are in the world. Good afternoon to my friends here in Brazil. It was a real pleasure to put this on internationally, and thank you for being a part of it, and thank you for my esteemed guests.